All right, everyone, welcome in. I'll give it a few minutes for everyone to trickle in. Share. Right. So, welcome to our Learning Together series, part 3, a community conversation on MOUD medications for opioid use disorder. We are so glad that you are here and joining us today. So, quick agenda. So, welcome and housekeeping, some information about Unshame, North Carolina, webinar overview. We're going to introduce the panelists and then go into our question and answer. So, before we get started, we want to ensure that we are grounding ourselves in respect. So please feel free to introduce yourself in the chat. We have a Q&A button. Use that to ask any questions you might have. You can also put any questions that you have in the chat. This session is being recorded, and a copy of the presentation will be available on our website. And then certificates of attendance are also available upon request. We ask that you come in muted, but like I said, please use the Q&A. We want this to be as interactive as possible. To access closed captioning, click More, select Language and Speech, and choose Turn on Live Captions. I also want to shout out the amazing interpreters that are here with us today. To adjust your view and see all speakers, please click View at the top of your screen and then select Speaker, and then we will have the Q&A. So what is Unshame North Carolina? Unshame North Carolina is a statewide campaign led by the North Carolina Department of Health and Human Services in partnership with Shatterproof, which is a national nonprofit. Our goal is to remove the stigma around substance use disorder through a community-driven approach focused on awareness, education, and uplifting the voices of lived experience. So the Unshame North Carolina campaign works by partnering with communities across North Carolina to reduce stigma around SUD through education, storytelling, and resource connection. And we also center lived experiences. So how can you get involved with Unshame North Carolina? We have 3 main ways. You can help us reach your community. So whether you encourage someone to share their story or invite them to become a coalition member, you can help us amplify the message. So stay informed and share knowledge with your family and friends. Like I mentioned in the previous slide, we're really big on storytelling. So if you want to share your story or know someone that would like to share their story, please feel free to connect with us. And then follow us on social media. So Facebook, Unshame North Carolina, and Instagram and YouTube is Unshame NC. And then this is a QR code that will take you to our link tree. There you will have information on how to sign up for our newsletter, our social media, or our story form if you're interested in sharing your story. And then if you have any questions, this is our email address right here. So the purpose, while we're all here, so medications for opioid use disorder are safe and effective. This is a conversation, a community conversation, and we invite you to listen to the different perspectives that are here, as well as ask any questions or get involved in the chat. We want to have this panel discuss their personal experience and then working together to reduce the stigma, improve access, and support well-being in our communities. And then without further ado, I'm excited to share who is on our panel. So we have Megan Peavy, who is also our moderator for today. She is a certified alcohol and drug counselor, certified peer support specialist facilitator, and her work has led her to Arise Collective. We have Reverend Arlisha Simmons, who is a faith leader, health advocate, and college educator. Her work centers strengthening congregations as spaces for healing, education, and hope. Dr. Logan Adams is a board-certified physician in internal medicine and addiction medicine. He currently serves as a medical director. Dr. Adams has authored multiple peer-reviewed publications on addiction medicine. And then we have Ashley Worth. Ashley serves as the Justice Service Lead and has done work as a peer support specialist, case manager, and licensed clinical mental health counselor. We are super grateful that these four have joined us, and I will go ahead and pass it over to Megan.
Thank you so much. And thank you everyone for being here. I'm really excited about this and grateful that we're going to have this conversation. So we're going to talk about some of the benefits of medication for opiate use disorder. So I will begin with answering a question and then go around and ask some of the other panelists some questions. So the question for me is, what was it like to start MOUD, and what long-term benefits have I experienced with treatment? And so starting medication-assisted treatment was incredibly difficult for me because there was so much stigma, and I felt so judged by everyone in the recovery community and society. And so I felt really small about it. But I had a peer support specialist who shared her experience with me and really encouraged me to focus more on my goal of staying alive and not my goal of remaining abstinent. The benefits of MOUD for me are immeasurable. So the life I live today is I'm incredibly blessed to be where I am and to have meaningful connections and genuine purpose in my life today. I utilized medication for around 2 years and tapered off. And what I know is that I would not be here without it. I wouldn't be who I am without it. And I know that no matter what someone's intentions are, the benefits from medication are life-changing and life-saving, and really worth discussing. And so, again, I'm really grateful to be here. So I will go to Dr. Adams. How would you describe the benefits of MOUD treatment to the everyday person?
Well, first off, it's really, really great to be here, and I'm so thankful for Unshame and C for this campaign and for these important conversations that we're having. And Megan, it's really hard to follow you because I think you encapsulated it so beautifully and so well. But what I would say just broadly about medication for opioid use disorder, so we're talking about buprenorphine or methadone, kind of the two main medications, are that whenever you start this medication for somebody with an opioid addiction, their chance of dying from an overdose is cut in half. Right, that's incredible, and there's not many medications that we have out there that have such a benefit like that. And it's not just that. In large studies that we have for medications for opioid use disorder, we know that folks' quality of life has increased. Their goals of reducing use or stopping use are increased compared to folks that aren't treated with medications. And overall decreased medical complications around substance use because oftentimes folks are using less or not using at all when they're on their medications. The medications work themselves by really binding to those same receptors in the brain that opioids do. And so when it does this, it treats somebody's really severe withdrawal symptoms that they have when they stop using. So when somebody is using regularly, they're going to develop tolerance and withdrawal. When they stop using, those symptoms are really unbearable from what my patients tell me, right? There's just really severe anxiety, restlessness, a lot of GI upset, body aches, can't sleep, just very miserable. And so these medications stop the withdrawal. And then they even help with cravings and discontinue cravings for opioids. So that's MOUD, I think, in a nutshell.
Thank you so much. Can you tell us what questions you commonly hear about MOUD treatment?
Yeah, absolutely. So there's kind of three main things that I've thought of that I hear pretty commonly. So the first one is, a very common refrain that you hear, and is that you're just replacing one drug for another. This is a really common myth that comes up, and it comes up with people that are coming in for treatment for medications, right? They hear this, but they recognize like, I really need this medication to help me through this period in my life, right? And that comes a lot with stigma, right? Just like in society, we stigmatize people who use drugs, we stigmatize the treatment as well. And there's a lot of stigma associated with these medications. And it is just that, right? It's a medication, right? This is a medication that treats a chronic medical issue, an opioid use disorder, right? And it has very clear, as I just laid out, very clear benefits for treatment whenever somebody starts this medication. And we don't treat other medications in medicine like this, right? I think of metformin or insulin, right? This is a medication-assisted treatment for your diabetes, right? But we don't give this weight to it as somebody doesn't have their diabetes under control if they're on a medication, right? So we don't do this with any other medication, and we shouldn't do it here with this medication. The other thing that I hear often is, I want this medication to really help me withdraw from the opioids as a detox, but don't want to be on this long term. So there's kind of two parts to this question. And obviously, we take everybody's goals and their goals in treatment and work with them and what that looks like. What we do know from large studies is that just detox from opioids, so if somebody goes to a detox program and they're not continued on medications, their rates of overdose are very high when they come out of those programs without continuation on a maintenance dose or therapy for a period of time. Um, and this is true for other programs that maybe treat opioid use disorder but don't actually offer medications as a part of that treatment. That is not the gold standard and mainstay of treatment, but that does happen. And what we know is that people that come out of those programs actually have a higher rate of overdose from a recent study that was done out of Yale a couple of years ago than if they wouldn't have entered treatment at all without medication. So medication is really critical as a part of recovery. Then the third thing that people often tell me, or that I often hear, and I really empathize with, is this idea of, doc, I don't want to be on a medication long term, right? I don't want to be on something for the rest of my life. And I hear that all the time in other spaces of medicine. When I started medication with my doctor, that's often one of the first questions that I have is like, hey, how long do I need to be on this, right? And so the goals of treatment are very individualized for everybody, right? For some people, they might be on it for a couple of years and then taper off, as kind of Megan shared. It was her story. Other folks, they may be on it for decades, right? But it's really all about what is the benefit that person is receiving from the medication, and does the risk of coming off this medication exceed that benefit, right? So this is a very individualized decision that's made, and one that I think as a medical community, we need to talk a lot more about the individualized decision-making process while somebody's on medication.
Absolutely. Thank you so much. So we know that medication for opioid use disorder is very stigmatized. So I want to talk a little bit about what it looks like when people in the community understand and support medications for opioid use disorder. It was just a incredibly inspiring thing to have providers and people in the community that supported and encouraged me. And so I didn't just go to the methadone clinic. I got engaged in therapy with their support. I got a referral to go to SAIOP. And so I was engaged in groups 3 days a week for 3 hours a day. I was involved in mutual aid support groups and was supported in sober living. And so with the support of people in the community, with a peer support specialist and individuals on the post-overdose response team that showed up for me when I was continuing to overdose everywhere in public, I was able to do that and found support, which just made me not feel small. It made it not feel like what I was doing was wrong, and it made the possibility of living a different life possible for me. It made it feel real. I think the biggest kinds of community support that can make the biggest difference is just safe spaces for people to be themselves, regardless of what their intentions are, right? For me, I knew I didn't want to be on medication forever, but I remember I came in and I was talking to people in my life and my therapist and my doctor and said, I just want to do this for 6 months. I just need 6 months. Let me just get a job and get a car and I'll be fine. And everyone said, let's just focus on today. We'll see where we're at in 6 months and see how you feel. And I wasn't ready. in 6 months, right? And that was okay. And, I work with women now who some are very engaged and inspired to not be on medication, and some want to be on it, and that's okay, right? So creating a space where people feel like no matter what path you choose, it's okay. And we're here for you no matter what. I think it's important that our service and our commitment to helping people isn't contingent on their behavior or what their outcomes are, but just on them being alive. And so, Dr. Simmons, we're going to come over to you. For many people, faith is a component of their healing journey. How can faith leaders help create spaces that welcome and support people that use MOUD as a part of their recovery?
Well, thank you for having me. Again, I'm here. I'm a member of the Partners in Health and Wholeness team for an initiative of the North Carolina Council of Churches. We've been working since 2018 with faith communities. It started off with 400 faith leaders across the church, across the state. And how I would begin the conversation is before the space is created, we have to confront a lot of the stigma that you've already addressed, Megan, and also just some of the stigma as it relates to chronic conditions that Dr. Adams addressed. And so one of the things in which we do our education is to meet people where they are in faith communities across the state. We have some congregations where they are creating rescue kits. And then we have other congregations where we're just trying to have the stigma reducing conversations so that from the pulpit as well as those who are in the pews, if they encounter someone who, let's say, comes to a food program or who comes to worship, that they're not saying the things that, Megan, you probably heard that turned you away from community. And so as a faith leaders, we're trying to get people just to understand the basics, just like you would not look at someone because they're on insulin, as Dr. Adams said. If this is a life-saving modality, and as we talk about from the Christian perspective, healing, that's one of our tenets of our faith, passion and healing. And so if we are to use the Bible and through the lens of theology in the Bible, if we saw Jesus as the ultimate healer who did more healing than preaching, then how do we embrace that there are different ways for people to be healed in our communities? So if that's insulin for the diabetic, fine. And so if the medication that you needed, Megan and others, if that's how you need to be healed, then we have to understand that it's not associated as it has been with sin. That's the other thing that we have to confront and we have to name. And so those are the ways in which we help faith communities across the state create spaces where people can not only come for worship, but people can come for our resources. And so that's why we're working with the North Carolina Department of Health and Human Services and trying to create hubs across the state where not only do people know how to have a basic conversation and remember the core tenets of love and compassion, then they also know not to say the wrong things that then will turn you away from community. Because at the end of the day, when we talk about healing, healing is about reconciliation. So Megan, as you talked and named the people who helped you on your healing journey, it was about restoring you to community. And that is one of the tenets of our faith, restoring people to community and getting people to understand, you can't, the same way you pray for those who have diabetes and anxiety and who broke a foot last week and, whose child has asthma, it's the same way in which we should care for those who may have been diagnosed with substance use disorder.
Thank you very much. Beautifully put. So I'd like to open up to the group. Any of our panelists, please feel free to jump in. Can you share a moment or experience from this work that really illustrates the impact that MOUD can have in someone's life?
I'll be the first to speak. So, I think when I was really impacted by what's really early on in my training, I was a primary care doctor for an individual who he was in his 60s. We'll call him Joe, and Joe had kind of your typical story that I guess the story that I often hear, right? I mean, this is somebody who had a really major motor vehicle accident in his 20s, developed severe chronic pain, was treated with opioids from the doctor, and then that use just kind of escalated, and then he was cut off from the opioids, and then turned to street opioids to really self-treat that severe pain that he had that really went untreated, and that turned to heroin, and then in the late 90s he ended up starting on methadone for treatment. And I was seeing Joe about 20 years into his recovery, and he was on methadone. Joe had gotten a job in finance. He had retired early from that job. He had 3 kids, and the goal that we were working on there was like, Doc, I'm still going to the clinic quite a bit, right? But I want to travel, right? I want to enjoy my retirement. And so those were the things that we worked with together, right? But I think it was in that space of getting to see somebody live in recovery on medication, it just a life that everybody else has and hopes for and wants, right? I mean, I think that piece, when you see that experience and sit across from somebody like that, and that's why I think it's so important to hear stories and hear people's stories and their experience, right? Because that just humanizes it for us, for those of us that don't have that lived experience, right? And so I think that piece was really impactful for me, and one of the reasons why, working with Joe, why I stepped into this field.
Ashley, would you like to answer?
Yeah, I will share that. For me, it's really hard to tease out the difference between personal and professional experience. I'm also someone who's in long-term recovery, who utilized medications for quite some time, and get the really privileged experience today of wearing that hat of someone with lived experience, as well as hats of someone that has been in that direct service role and now work on more of a policy systems level. And so being able to like pull all of those things together, I thought that I was unique in a lot of ways, that when I started taking medication, there was so much stigma against it. And I started taking this medication and suddenly was able to manage my life. It just took one of multiple things off of my plate. I no longer felt the need to seek illicit substances, and had stability in that way, which opened up opportunities for me to, finish a college degree, take care of my children, all of those other pieces of life that people enjoy freely. And all I had to do was take a medication every day. Like that was it. It like opened up all of these doors. And then later I got into, I was a licensed clinical addiction specialist, case manager, peer support, all of those things, working for nonprofits and working with people who were using drugs quite chaotically. And then I saw that same thing happen again and again and again. People would enroll in the local opioid treatment program. I know most people in plain language know that as the clinic. And so people would start going to the clinic and receiving life-saving, life-changing medications. So methadone at the time, and bupe was more. It was a really interesting and continues to be this like double-layered stigma of you can receive one medication at your primary care physician's office, and then this other medication you have to go to a specific location for. It didn't matter with both of those medications. I would see people who were suddenly able to work their Child Protective Services case plan. They were able to, go to a whatever job, SAIOP, whatever the things were. They were successful on community supervision or probation. And so just seeing that like all come together and being able to align that with my own personal experience, it's just such a phenomenal impact. Like it truly is life-changing.
Thank you so much. Does anyone want to share more about their own journey toward MOUD acceptance, if it was a journey for you?
I did want to comment on something Dr. Adams said about just the community looking at individuals like, well, in our congregational context. Sometimes when we think of healing, we think it has to be instantaneously, because of the healing stories that are throughout the Bible. Like, you had an encounter with Jesus, you are healed. Go and, take up your bed and walk. And I think the challenge is to just getting people to understand and accepting that this is just like you need other medications to manage. You're not just exchanging one addiction for another, because I've heard that conversation in our context of people just not having the understanding. So going back to your last question, that's why it's so important when peer counselors and people with lived experience have opportunities to speak in our congregations. About 2 years ago, we invited someone, you might know Charlton Singleton, came in and talked to our congregation, and to see people's eyes look at him like, oh, wow, because a lot of people have a perception of people who are in recovery that you look one certain way, and then you see this person who's so articulate and just a powerful speaker. So when you have those encounters, then you can have another conversation and talk more about the medication and talk more about the process of recovery, because your context is, oh, you should be immediately delivered. You should be immediately healed, and not realizing that sometimes the healing happens and it's a lifetime experience. So you have the testimony. Ashley now has the testimony. And I appreciate hearing all of your experiences of the ways in which you've continued to work and serve the community, even as you are navigating your own experience.
Thank you so much. So we're going to shift to a discussion about the access and availability of MOUD. For me, having access to treatment was incredibly easy. I had a peer support specialist navigate my referral prior to when I got sober. So January 25th of 2019, a couple years before that, through the North Carolina Harm Reduction Coalition, I was connected with a different provider in the area. Both times were incredibly smooth. All I had to do was show up. Transportation was provided for me. They were on a bus line, and I live in Wake County, and in Raleigh we have public transit that at the time we were given free passes for. And so access for me was incredibly easy, which surprised me because I didn't know about it. No, it wasn't posted anywhere. People weren't talking about access to MOUD. There wasn't websites or if there were webinars and information like this, I didn't have access to it. There were no campaigns to end stigma. And so it surprised me because for the first time, I think in my recovery or actively using substances, it became aware for me that that people cared and that it was okay that I lived my life the way that I did and that help was available to me and all I had to do was show up. And so I am very aware that that's not the case for everyone, and it's not the case for a lot of people in this state and in this country. But that was my experience, and I am incredibly grateful for that. Ashley, we often hear that accessibility is the biggest barrier to connecting MOUD to the people who want it. So what does low barrier access to MOUD mean to you?
Just want to say, Megan, that what you just described is like the dream for all people, right? Like we want it to be easy. We want folks to have access to transportation, peer support, someone to really like hold their hand through the process, help them eliminate whatever internalized stigma they may hold, which is just a part of that low barrier access, right? So when I think about low barrier, it's literally that. You are removing barriers. You are removing unnecessary rules, long wait periods, the need for a screening and then a referral and then an assessment. And then finally, a week later, you're able to take a medication. It's getting people in, not keeping them out. I think about the transportation obviously is such an issue, especially I'm a rural North Carolina girl. I grew up in the Appalachian Mountains. And if I were to be, even today, trying to access an OTP from my hometown, it's a 45-minute drive. And when you start thinking about all of the barriers that are created by our legal system, and, I have been chaotically using substances and don't have a driver's license, or I don't have access to a vehicle, like all of those things just so many unnecessary challenges. I also think about like the OTPs or doctors' offices themselves, removing those barriers around the limited hours that you're open and extended hours, making sure that your entire staff, from the front desk person to the janitor to clinical supervision, are trained in trauma-informed approaches and like lead with that driven person-centered care, so that it's not another person being a barrier, it's not an unnecessary policy that's a barrier, and it's not a process that is way too complicated for even the most stable human being on earth to navigate.
Thank you so much. Where do you see, Ashley, the greatest opportunities for policymakers to partner with community in this issue?
I love this question, and it's also incredibly difficult because when we talk about policymakers, we're talking about so many different levels, right? So I think that if you're a policymaker in the organization that you work for, really assessing those policies to see are there barriers, are there rules, processes that just aren't actually needed or necessary. In communities, I think a lot about like zoning laws and the pushback that we get for, doctors' offices wanting to open, an opioid treatment program wanting to come in, mobile units. We now have the availability of mobile treatment programs, and yet there is still pushback in neighborhoods and communities of like, well, we don't actually want that van pulling up here. And so really working to eliminate those things so that people do have access to treatment. And then we can go a little further up and say that if you're in like state government, it's funding, or federal government, it's really funding and being intentional about that funding and making sure that when we are appropriating dollars to programs, that those programs allow people to take medications. Which is something that unfortunately we see far too often, that, programs are saying not only can you not take a medication for opioid use disorder, a lot of these programs won't allow you to take a medication for depression. And so you are screening out a huge population of our most vulnerable citizens.
Thank you so much, Ashley. So each one of you brings a different perspective: faith and policy, lived experience, healthcare. What does meaningful collaboration between these sectors look like in practice? It's for anyone.
I can answer that question. I do want to make a correction. I was speaking of Charlton Rover. I said Singleton. So I'm sure some of you know him. I think meaningful connection and collaboration. That's the great thing about my job. We are called Partners in Health and Wholeness. So we're always connecting pieces of a puzzle. And I think sometimes with faith communities, they want to help, they just don't know how to help, or they don't know where to enter. So as you were talking about transportation, Ashley, transportation is an issue that congregations, depending on your readiness to be involved, can, approach. You may not be able to offer space for, let's say, a group meeting. You may not have a knitting ministry where you can create naloxone kits, but maybe you have a church van, you have someone available to drive. So if someone needs care, or if someone needs to get to their appointments or their therapist or meet with their counselor, maybe that's a service that you can provide. And so sometimes, that's what we attempt to do: help churches understand the community assets as not only what they can get, what resources and services they can bring to the congregation, but then how they can be an asset to organizations. And whether that's through space, whether that's through physical items of providing those items, providing snacks for a meeting, or something that's tangible that someone might not think about. Well, how's that addressed? Well, people are going to be there all day, or they're and they may need water, they may need something that just provides some type of care. But I think it's having an openness from my our faith communities, of understanding sometimes we don't have to reinvent the wheel because there are already programs in existence. And so we always stress collaboration. Maybe if there's a church nearby, they're already doing work in harm reduction, join in with them and learn how to be involved in that process before you just go and launch something. And so that's one of the things that we stress with collaboration. See, I'm calling you to be in the bigness, in the largeness of the wind. It could be in the still small voice of responding to the issue.
Yeah, it's a huge question, and I think Dr. Simmons really answered it really beautifully. I think also I think of this often as expertise, right? So each of us has our expertise, right? And my expertise, I know a lot about the human body, the physiology, how medications affect that, right? But I'm not somebody that has a lived experience of substance use. I don't know what it's like to use a toxic drug supply, to overdose on those drugs, right? I don't know what it's like to live in recovery, right? And there are people with that expertise that can speak to that far better than I can, right? I don't have a first degree relative or somebody with a substance use disorder. So I don't know what it's like to be a caregiver in that role for somebody and walk with somebody in that journey, right? But there are people on this webinar that do, right? And each of you has expertise in the spaces that you're in, right? And it's figuring out how to leverage that expertise to achieve this goal. And I think that the goal of this is stopping stigma around medications, right? We're in different spaces, but we can use our expertise. And I think as a doctor, I'm privileged to spaces that a lot of people aren't privileged to, right? And that's just the reality of our society, right? And so I have to use that privilege and that space well and wisely to advocate and push these things forward. So I would encourage everybody to think about what is their expertise, what are the spaces that they work in each day, and how can we make these spaces safer for our folks that are using drugs and advocate for their well-being.
And I would just add to that although we all have our own like individual spaces that we are like fluent in the language and walk in and out of every day, it's coming together to teach and to learn, with each other. So every time I sit down with one of our like medical directors or other experts in that part of the field, I learn something new, and that is something that I'm then able to take into the spaces that I frequent and say, actually, I just learned this the other day. Let me tell you about it. And so have those like very intentional spaces where we all come together to both teach and learn from each other.
Thank you so much. For anyone who may still be unsure about medication for opioid use disorder, what message or perspective would you want them to understand?
I think just to sum up, medications for opioid use disorder is the gold standard treatment, right? It saves lives, and people recover every single day, right? I mean, I think I'm really privileged that I get to, and my day is full of this, right? I get to walk into one room and I get to see somebody that's in pretty active substance use disorder and know that I have a really effective treatment for them and that there's hope. And then I get to walk into the next room and I get to see somebody that's lived in long-term recovery, right, on that medication. So I'm really privileged to have that ability in the work that I do. But if you know somebody on this call, or you or maybe somebody that is living with a substance use disorder, know that there is hope, there is recovery, and I think all of us on this call can attest to that. We see that every day.
And I would say, from my perspective, just to leave with love and compassion. So I do have a first degree of having loved ones with substance use disorder and watching over decades from childhood to adulthood and seeing the recovery of health, the recovery of spirit, the reconciliation of family. And so when you lead with love and you believe in the tenet of hope and compassion, if there is something that then allows for the healing restoration of a loved one, just you think about, am I my sister's, my brother's keeper? And, that's one of our tenets. If we lead with that perspective, and I want this person to be whole, just like I want myself to be whole, I think that would help a lot of people to not stigmatize it and see it as finding an excuse. No, it's not an excuse. It's an opportunity. It's a modality of healing, for restoration and healing, and for them to have an amazing testimony that hopefully will help someone else gain independence, gain hope, gain reconciliation with their family, and hopefully experience God's love in the process because of the people who you've found and they've surrounded you in the process.
I think a lot about the language that we use. And, a few years ago, it was medication-assisted treatment, and now we refer more commonly to medications for opioid use disorder. And it's important to take all of the extra pieces out of there, right? It's just medication. It's just treatment. It doesn't have to be this big, complicated thing. If I have a headache, I take a medication, it treats my headache. If I have an opioid use disorder, I take a medication, it treats my opioid use disorder. And it really is just that simple. It's a medication. And we are fortunate, privileged enough to live in a world where medication is available. It's no longer the late 1800s. And if I have what we would now call an opioid use disorder, my options were pretty limited. Now we are privileged enough to live in a world where we can just take medication. And so, I know it's a lot of mental gymnastics sometimes, but if we just pause, look at it, and take medication, and that's it. It really is just that simple.
Thank you so much. And I believe we are going to answer if anyone has any questions for the panelists.
Please feel free to put questions in the chat. We can give a few moments for any question that might come through in the chat.
Also make a comment while we wait for questions. If you know of a congregation or you're a member of a congregation, I know we have some clinicians, and your church wants to begin the conversation, please give us a call at the North Carolina Council of Churches, Partners in Health and Wholeness, because we do have webinars that we do support, as well as we can physically come into your space with people and answer questions and have this discussion, so we can kind of begin a discussion and determine your readiness to reach out more and to just decrease stigma in this area.
Yeah, and I'd love to open it up to any of our panelists if there is anything else that you want to share before we move on. I have some closing slides. I want to open it up to if you all have anything you'd like to share before we close off. Really, we have a question that just came through. Dr. Simmons, what have you found is helpful in helping religious folks understand what recovery with medication is, recovery versus abstinence?
Thank you for that question. Actually, one of my colleagues, Donna Parks-Hill, works in this particular area. So she has a workshop that what we do is we come into communities, and based on what county you're in, we partner with individuals in that particular county or even from the state who can come in and help people understand the language. Sometimes people don't necessarily understand the language, and then they have opportunities to hear, like as we started, Dr. Adams just kind of breaking it down in medical terms to understand. The same way that opioid works, it works to the the receptors, to use those medical terms for people to understand, like, oh, okay, well, my brain is used to this, now I'm telling my brain it can have it. So sometimes giving them the understanding of it. And when we say, for people say, oh, well, you just need to abstain, but helping people understand it is a medical condition. It's not just, people with cold turkey. I've met people, Adams as well as Ashley and Megan, you've met people, you've done it cold turkey. Test, you do the people are, people thrive when they have the medication. So it's just having those conversations that we don't necessarily have space to have on a Sunday, but we might have to come into a webinar or a workshop, give them some of the help understand how the brain works, how the brain functions, help them understand how naloxone works. One of the things that we do trainings and getting people to understand, like, trust is learning CPR. It's the same thing, just trying to help people get to more help. And when we break things down, then people who may come in with a super religious lens then say, oh, okay, I get it. I think that's just for us, the best way to help people get to a point of not just attaching something to it, but understanding it and moving it beyond theology. Because, Jesus worked in his divinity, but Jesus also natural elements of healing people, of telling you to use water or spitting or whatever natural elements that were around. And so we talk about just using those natural elements. Meditation is one of those natural elements. And if we can see it as it's helpful when we may have that discussion of versus abstinence.
A few questions coming through the Q&A tab. Folks I've been working with recently have been running into issues accessing when they transition from the. Any suggestion on how we keep folks on their MOUD?
My assumption is that you are referring to state prison and not a local detention center or jail. And currently in our state prisons, MOUD is not available unless you are a pregnant person entering the prison system. There is, and they have gone to great lengths to implement MOUD at release for eligible individuals. And then in local detention centers, that's different. I mean, it's a very complex system. It's very different rules and regulations for either the state prison system or local detention centers. We do have a lot of local detention centers that are allowing people to continue on their medications. And there is definitely work to be done. If that is the system that you're referring to, I strongly encourage everyone to advocate locally for that.
Yeah, I want to add to that because actually broke it down really the local jail. So there's one thing, but the local jails, it's just done differently in every county. So the organization, we're in 8 counties, and 8 different jails do it differently, and it's been a lot of advocacy to say, I don't know where the questioner works or what their role is, but even if you're not in like the healthcare space, advocacy is so important. Like we need legislation that mandates this in the jail. So major professional organizations in the state of North Carolina, like our addiction medicine organization, ASAM, NC Todd, we've written a shared brief about continuing people on medication when they go and are incarcerated. And other states have mandates, our state does not. And so this is something that really you can advocate on. Call your legislator, right? And say, look, this is happening in my community and we need legislation. And I think really legislative advocacy is what's going to push this forward.
All right, thank you for that. Let me share my screen really quickly. Okay. Here we are. So just want to thank everyone for being a part of this conversation. I want to thank our amazing panelists for bringing their perspectives, bringing their different avenues to this conversation. Huge shout out to Megan for moderating this wonderful conversation. I would love for you to scan the QR code and just write some feedback for this webinar. What would you like to see for future webinars? And just have a conversation with us about this webinar. And then join us for part 4. So join us on June 16th at 2 p.m. for part 4 of our webinar series. This will be a community Q&A on substance use and recovery, and we'll be joined by members of our Community Impact Committee. So super excited for that as well. So thank you all so much for joining. Thank you, our panelists. Thank you to our amazing interpreters. And thank you all for just being here and joining us for this wonderful conversation. And the learning doesn't stop. We're going to continue learning together. So please join us for part 4. And with that, I hope you all have an amazing rest of your day. And thank you all again so much. Mom.